Neurology, Pathology, Adult Primary Brain Tumors. All right, so first off with the brain tumors, this was probably my least favorite section to study and learn, but I'm going to try to break it down once again in a digestible manner so that you guys don't struggle with it as much as I did. So starting off with the first most common primary brain tumor in adults, all right? And this is glioblastoma, all right? Now, glioblastoma is a very, very scary disease, very scary cancer. It has about a 1-year survival rate, okay, after diagnosis. So once again, it's the most common primary brain tumor in adults, and it is one of the most deadly brain tumors in adults. Now, what you need to know is that it contains areas of necrosis and hemorrhage. Okay, so there's a central area of necrosis and hemorrhage on histology. All right, and they love to ask about that. Specifically, surrounding the central area of necrosis, you have a pseudo-palisading tumor cell type of morphology, all right, with increased vascularity. So when you take a look at glioblastoma under a microscope, you'll see kind of a bunch of cells that, like, you see all the nuclei kind of lining up together surrounding a central area of necrosis and hemorrhage. And that area around the central area, or around the area of necrosis, is going to be known as pseudo-palisading tumor cells. And pseudo-palisading just means that it looks like kind of like a picket fence, essentially. Okay, so take a look of what pseudo-palisading looks like under microscopy for histology, because it could show up sometimes. Now, something that you need to know about this is that it's poorly circumscribed, and it crosses the midline. Okay, so if you ever see some type of adult brain tumor and they show you the CT scan and it's crossing the midline, chances are it could be glioblastoma. So that should be the number one thing on your differential. All right. Now, they want you to know the cell origin of glioblastoma. It's astrocytes. Okay, so it stems from astrocyte cells, okay, within the brain. All right. Now, it's associated with EGFR amplification. That's probably the last thing that you need to know about glioblastomas. So, once again, glioblastomas are the most common primary brain tumor in adults. It crosses the midline on CT scan. On histology, you're going to see it's going to be pseudo-palisading with central areas of necrosis, and its origin is going to be astrocytes. All right. It has specifically an association with EGFR amplification, and because of its astrocyte origin, it will stain positive for GFAP. All right. That's it for glioblastoma. Moving on is oligodendroglioma, one of the lower yield ones. But if you see fried egg cells or chicken wire capillary patterns, then you know you're talking about oligodendroglioma. But once again, lower yield. Meningioma. Meningioma is going to be a tumor cell that arises from the arachnoid cells, all right? Specifically the meningoepithelial cells of the arachnoid. Okay, so they can say meningothelial cells of the arachnoid. And they can form in the spinal cord, located within the meninges in the intradural extramedullary space. And they usually have an association with like Samoa bodies and spindle cells in a whorled pattern. So if you see Samoa bodies or spindle cells or whorled pattern, that's talking about specifically meningioma. Now, they love to say the word extraaxial when discussing meningioma, which makes sense because I already told you that it can form in the spinal cord located within the meninges in the intradural extramedullary space. When we say extramedullary or extraaxial, it means that it's not within the brain tissue, essentially. Okay, so it's going to be within the meninges. All right. Now, what that you will also see is kind of like a dural attachment. So these, take a look at what meningiomas have with dural attachment. Just like search that online, CT scan. You'll see kind of like tails coming off of the meninges or of the mass. Okay, and that's going to be indicative of a meningioma. Another thing, kind of just a quick, fast, hard rule that I always kind of think of. Whenever you see kind of like a mass within the spinal cord region or on the surface of the brain, I think that you should just immediately start thinking of meningiomas because they present with along the surface of the brain or within the spinal cord. Now, a high yield association is that it also is going to have cerebropontine. It's going to form a mass in the cerebropontine angle. All right. And so that can often affect the cranial nerve 8 and lead to hearing loss. So you could potentially see hearing loss with patients that have meningioma. Now, we're going to talk about another adult primary brain tumor known as schwannomas. And schwannomas also affect the cerebellopontine angle and it also affects cranial nerve 8. But you're going to need histology to differentiate schwannomas from meningiomas. So they won't really ask you the difference between those unless they provide histology. If they provide histology, you know that the meningiomas are Samoa bodies and have spindle cells and whorled patterns, okay? But if they don't give you histology, then they're not going to ask you to pick between meningioma and schwannomas because they both can affect the cranial nerve 8 and the cerebellopontine angle, okay? So once again, reviewing meningiomas, these are going to be along the surface of the brain or the spinal cord, hence extraaxial, so it's not in the brain parenchyma. And they're going to have some type of dural attachment on imaging, so it has like a little tail. They can arise in the cerebellopontine angle and affect the cranial nerve 8, leading to hearing loss. They can arise from the meningothelial cells of the arachnoid, okay? And they form in the spinal cord located within the meninges and intradural extramedullary space. Once again, that's just telling you that it's extraaxial and in the meninges. On histology, you're going to see Samoa bodies and spindle cells in whorled pattern. Okay, so take a look at what those look like under histology. Next is hemangioblastoma. Once again, a little bit lower yield, but what you do need to know is that it's often cerebellar. Okay, so if you see like a mass in the cerebellum, that can give you a good hint about it being hemangioblastoma. So it's going to be in the posterior fossa, right? We know where the cerebellum's at. And the origin cell is blood vessels. Okay, so it originates from blood vessels. So what you'll see is dilated capillaries with thin connective tissue septa. Okay, and what they like to talk about it is it being a purple vascular cluster. All right, and that's hemangioblastoma. All right, so keep that in the back of your mind. It has a high yield association with von Hippel-Lindau syndrome. We already talked about that, right? Remember, VHL has the HARP. They have the HARP associations, and that's hemangioblastoma is the H. The A was angiomatosis. The R is the renal cell carcinoma or clear cell carcinoma, and the P was pheochromocytoma. So once again, this is the H seen in VHL of HARP. So hemangioblastoma is associated with the VHL syndrome, all right? And so hemangioblastomas are going to be potentially could be seen with cysts in the kidneys, in the liver, or in the pancreas, just because of its association with VHL, all right? VHL disease. Next is going to be pituitary adenoma. This is very, very high yield, but it's very easy to understand. So I don't really clump it with the adult brain tumors, but it is like essentially an adult brain tumor. It's very easy, right? We know that this is going to be mainly pituitary adenoma, most likely is going to be caused by a prolactinoma, right? And so the prolactinoma is going to be present and it's going to cause pressure on the optic chiasm, leading to bitemporal hemianopia, all right? So you have the loss of the lateral vision in both eyes. You are going to see like galactorrhea, amenorrhea, right? Decreased libido when it's prolactinoma. It could also be growth hormone releasing type of adenoma, but remember, majority of the time it's going to be a prolactinoma, not growth hormone, all right? So the treatment's going to be a dopamine agonist, right? And so you could give them bromocriptine or cabergoline, and then like ultimately, if none of those work, you have to do a transphenoid resection. So you just essentially go through the nose to resect the pituitary adenoma. All right. And once again, it's most commonly from the lactotrophs, which produce prolactin. All right. Very straightforward, very easy to understand that. Now, something that's somewhat related, what if you see bitemporal hemianopia in a patient? All right. Majority of the time, you're going to pick pituitary adenoma. But let's say that's not an answer choice. Exactly. It could be caused by a saccular or berry aneurysm, all right? I'm just calling back to what we've learned previously, right? So a anterior communicating artery that has a aneurysm present on it, saccular aneurysm or berry aneurysm, can cause bitemporal hemianopia because of the compression of the optic chiasm as well, okay? So just trying to connect those dots for you. Lastly is the schwannoma, which we discussed. Classically, it's going to be at the cerebellopontine angle. So once again, if you see cerebellopontine angle, it's going to be schwannoma or meningioma. Now, it's going to be often localized to cranial nerve 8, so you're going to have some type of hearing loss and tinnitus in people that have schwannomas. It's highly associated with NF2, right? But NF2, the difference is that it'll have bilateral schwannomas rather than unilateral schwannomas. So usually schwannomas are unilateral, but in rare cases under NF2, you'll see them bilaterally. What they want you to know about schwannomas is that they come from the cell origin of the Schwann cells, right? So Schwann cells are positive for S100, Okay, very, very important for you to know, as well as a biphasic dense cellularity. So Schwann cells are S100 positive, and they have a biphasic dense cellularity, or cellular areas. Okay, very important to know for schwannoma. That's it. All right, so what I would recommend you do is take your time on these. I want you to kind of understand, one, where are each of these tumors? What are their cell origins? Okay. Number two, since you know their cell origins, you should know what they're positive for. Okay, so glioblastoma is positive for GFAP because it's astrocyte origin. Schwannoma is positive for S100 because it's Schwann cell origin. All right. Now, number three, I want you to understand the histology. Most importantly, glioblastoma is pseudopalisading with central areas of necrosis and hemorrhage. Okay. And then every single other one as well, right? They have important histologies. But I would say focus on the histology of glioblastoma, meningioma, hemangioblastoma, and schwannoma with a biphasic dense cellularity, okay? And then going to the description, I want you to kind of see what it looks like on CT scanning, okay? Glioblastoma crosses the midline. Meningioma has the kind of dural attachment where it's going to be located within the spinal cord or at the surface of the brain, right? Pituitary adenoma is going to be located kind of towards it's going to be closer to like the central portion of the brain, but it's going to be towards the front near the optic chiasm, right? And then the hemangioblastoma is going to be in the cerebellar area, all right? And the schwannoma and meningioma also are usually going to be involved in the cerebellopontine angle. So the location is important. And then lastly, I want you to know kind of the associated disease or pathology that they can be associated with. So like not so much disease or pathology, probably mainly, I'm thinking more like genetic diseases. So glioblastoma has the EGFR amplification, right? And then our schwannomas have the NF2 association. Okay, so those type of things. Our hemangioblastoma has VHL association. All right. When you have all of that figured out, you should be good to go. So once again, understand the cell origin, understand what it's positive for, understand what the histology looks like and how you can describe it in words. Understand for description wise, understand where the location is of each one of these on CT scan. And lastly, understand the genetic variation of each one of these. All right? And you should be good to go.